Hello, friends. So today I'll be talking on this pulmonary thromboembolism. So I'll take you through the whole overview of this topic. So recently we had a masterclass session on this pulmonary thromboembolism. So I thought it's better I take you through the salient points that we discussed during the meet, and it would be useful for most of the exam going trainees. So when you look at the epidemiology of the venous thromboembolism, so the 2003 US survey showed that the 15 million medical patients who get discharged from the hospital would be at a risk of developing venous thromboembolism. And 51% would qualify as someone who falls in the risk category of developing venous thromboembolism. So if we look at the occurrence of DVT or deep vein thrombosis, it is about 53 to 162 per 100,000 patients. And when you look at the pulmonary thromboembolism, it is around 39 to 115 per 100,000. So this is predominantly from the US data, and this is the prevalence rate of DVT and PE. And it is also referenced PTE is the common preventable death, and it accounts for 1 to 2 lakh deaths in a year. So which means to say, all in all, epidemiologically, it appears to be a significant problem, contribute to significant morbidity and mortality. And venous thromboembolism constitutes third leading cause of vascular death, following the acute coronary syndromes and the stroke put together, which means when we take the vascular events as the cause of death, following MI or acute coronary syndrome and the stroke, venous thromboembolism seems to be the commonest cause. So it's the third leading cause of vascular uh, sort of a death. So as a problem overview, so in US and in across the globe, so there are various societies putting a lot of emphasis on taking measures to prevent venous thromboembolism. So the National Quality Forum, Surgical Care Inpatient, Surgeon General, JACO, CMS, all of them have put a prevention of venous thromboembolism as a number one strategy to improve the safety of the patients who are within the hospital and even post-discharge from the hospital. And the benefit clearly outweighs the risk by employing or by deploying this as a number one strategy, which is desirable and appears to be very cost effective. And there are numerous evidence-based medicine guidelines suggesting all the measures that one needs to put in place to prevent the occurrence of venous thromboembolism and the measures to treat venous thromboembolism. So when we look at pulmonary thromboembolism, so there are clearly defined risk factors. So some of the risk factors are pre-existing and some of them are acquired. So some of the pre-existing risk factors are obesity, where body mass index is more than 30 qualifies as a risk factor. I've just put in a very pictorial format for you to just remember what are the salient sort of a risk factors that put someone at the risk of developing venous thromboembolism or pulmonary thromboembolism. So anyone with a stroke, so someone with a history of smoking, and anyone more than 35 years who is not very ambulatory and who's had a previous venous thromboembolism or thrombophilic states or a procoagulant state, or someone in ICU with sepsis, or any individual with a heart failure or respiratory failure or end-stage lung disease like COPD or inflammatory lung conditions. One important risk factors, when we look at all the risk stratification models, for all the listeners or for all the trainees, one need to bear in mind a lot of emphasis or importance is given to the underlying cancer as a very important risk factors, or previous venous thromboembolism as a very important risk factors, or the presence of thrombophilic state as one of the important risk factors. This alongs with someone who's had a vascular event, be it a coronary event or be it a cerebrovascular event, puts them at a higher risk. I think if you remember these as a very important risk factor should suffice. So anyone with any chronic inflammatory conditions like inflammatory bowel disease, or someone who has undergone major surgery also qualifies as a risk for venous thromboembolism. Someone with the indwelling catheters, and this is very typical in someone who is undergoing dialysis, who have a dialysis catheter sitting, definitely puts them at a higher risk of developing venous thromboembolism. So this is pictorial representation, as every sort of a candidate could recall this picture and remember. So, but the quintessence is to keep cancer and previous vascular events or previous venous thromboembolism or thrombophilic state as the important factors which put someone at a higher risk. And in pregnancy, someone who's had a hyperemesis issue or ovarian hyperstimulation syndrome, or someone who's taken a long flight more than 4 hours, all these are other relative risk factors for pulmonary thromboembolism. So when we look at the pathophysiology of pulmonary thromboembolism, every listener would possibly be aware of this virtuous triad, where there is a stasis of the blood or a thrombus formation which acts as a nidus and coagulopathy. All these three put in together will constitute a conundrum to create a risk for venous thromboembolism. And when we look at pregnancy, venous thromboembolism risk occurs from first trimester to the third trimester. The risk does remain for someone to develop venous thromboembolism. And half of the patients who develop venous thromboembolism or pulmonary thromboembolism occurs at 20 weeks. And 75 to 80% of them tend to have a risk for developing DVT, of which 10 to 12% develop a risk for pelvic vein thrombosis, and 20 to 25 are at a risk of developing pulmonary thromboembolism. And pelvic vein thrombosis predominantly iliofemoral. And as I said, the risk increases 20-fold in postpartum period. 12 weeks postnatal, the risk of someone developing venous thromboembolism or pulmonary embolism goes up to 20-fold. So, which is an alarming and a disastrous sort of a risk that increases in pregnancy. And first 3 weeks is the highest risk. So, which is after delivery, the first 12 weeks constitute the risk, of which the first 3 weeks constitute the highest risk, where it increases by 20-fold. And left lower limb DVT is more common in this pregnancy, 90% versus 55%, and iliofemoral seems to be the commoner risk factors. So when we look at a little more into the risk factors, so it is said the in hospitalized patients, someone who is within the hospital, the risk of venous thromboembolism is very high, up to 130 times. And this increases with proportionately with the increasing age. And the males are at a higher risk of developing venous thromboembolism. And as you see in this, these are the two studies which cite that 60% of the venous thromboembolism occurs as a risk due to hospitalization, which means there is a tremendous amount of emphasis on the hospitalized patients. The fact that they're within the hospital itself increases the risk of venous thromboembolism very significantly. And 45% of venous thromboembolism tends to occur within 90 days after they have been discharged from the hospital. So the fact someone is within the hospital and post-discharge increases the risk of developing venous thromboembolism by 45%. So this is a study from Australia in 2011, which is a very large data set of 175,000 in 134 ICUs, where they've compared the risk sort of a difference between patients who got thromboprophylaxis versus no thromboprophylaxis, and they found the ICU mortality was significantly less in patients who got thromboprophylaxis, and so was the hospital mortality was significantly less. And the attributable mortality of venous thromboembolism, as you see, was found to be highest in patients who sustained cardiac arrest within the hospital, 15.4%. This was followed by metastatic cancer, sepsis. So for all my ICU friends, sepsis is a very important risk for someone developing venous thromboembolism. That's why putting patients on thromboprophylaxis in ICU is a quality indicator, and every ICU patient, sick ICU patients fall under high risk for developing venous thromboembolism, and they should be on thromboprophylaxis because 8% is attributable mortality, and in trauma it's 3.9%. So when we look at pathophysiological aspects of this venous thromboembolism, predominantly the pulmonary embolism, because today the topic is more focusing on pulmonary embolism, is usually bilateral, and it tends to occur in the lower lobes more commonly, and 10% of them can develop pulmonary infarction due to occlusion of the pulmonary vessels. And here you see there is, because of the occlusion of the pulmonary vessels at the vascular level, at the alveolar level, there is a ventilation perfusion mismatch, which means to say there is effective ventilation here, the alveoli that is happening, but there is no perfusion due to the formation of these microthrombi within the pulmonary vessels. And because of these microvascular thrombi formation within the pulmonary circulation that happens, there is increase in the pulmonary artery pressure. And it is shown that pulmonary artery pressure increases when there is 30 to 50% occlusion of the pulmonary vasculature. and there is increase in the pulmonary vascular resistance. So all this will be indicated in acute pulmonary embolism. When such occlusions happen with increase in pulmonary artery pressure, when there is an acute pulmonary embolism involving major vessel, so there are certain structural changes that happen in the heart because there is a load on the heart. So this is the echo sort of a window of the heart. I've just put it in a pictorial format. So this is the LV, this is the LA, this is the RV, and this is the RA. So you see there is an acute right ventricular dilatation that tends to happen. And there is a dilatation and there is a TR jet, tricuspid regurgitation jet into the RA that happens. And because of this increased strain on the RV, this interventricular septum is pushed to the left ventricular. That's why you get a straightening of this interventricular septum, or we call it as a D-shaped interventricular septum or a D-shaped RV, right ventricle. And because there is increased load on the RV, because of this occlusion of the pulmonary vasculature, there's increase in the afterload of the RV. And this leads to right ventricular dysfunction or right ventricular failure, which can be ascertained by doing TAPSE. So if TAPSE is less than 16, then there is RV dysfunction. 8 to 16 is moderate dysfunction. Less than 8, there is RV failure. And because RV dysfunction tends to happen, and because there is movement of this interventricular septum into the LV filling pressure comes down, and that can lead to lowering of the cardiac output. And that is when the whole biventricular dysfunction sets in and low cardiac output sets in due to the obstructive shock. So these are the physiological changes that tends to happen when there is pulmonary vasculature occlusion. There is a load on the RV dilatation, increase in the RV afterload, and RV dysfunction, leading to effectively later on leading to reduced LV filling and low cardiac output state. And when all these are happening, there is a conduction abnormality, and the patients can develop right bundle branch block as well. So echo abnormality in pulmonary embolism is only seen in 30 to 40%. And the typical echo findings you would see is there is a large RV, which I mentioned. There is an underfilled LV, and there is a displacement of the interventricular septum into the LV, leading to the D-shaped right ventricle. And there is a prominent apex, which we call as McConnell sign. So this is the typical echo sort of a finding that you would see in the acute PE, where as you see the RV is dilated and this is a D-shaped septum, and the LV filling comes down and there is a low cardiac output state. So this is typically pictorial representation of the typical echo findings that you tend to see. And another important thing, if there is a major thrombus sitting within the pulmonary artery, in the parasternal short axis view, you can visualize the thrombus. So this video will very briefly show you, very carefully watch. So this is the right pulmonary artery. You will see the presence of thrombus. So this is the right pulmonary artery, and this is the thromboembolism. I'll just show you. So you carefully watch the video. You will see there is a thrombus floating here in the right pulmonary artery. Carefully keep watching. See, you can see that bobby thrombus floating in the right pulmonary artery. So what are the symptoms and signs in pulmonary embolism, which we discussed during the master class? So when the key essence of pulmonary embolism is to identify, because if there is no identification, no treatment, death happens in 30%. But if the identification is done and appropriate treatment is done, the death could be reduced to 8%. When we look at symptoms, so 73% of them will have dyspnea, 66% is said to have pleuritic pain, 37% have cough, and 13% have hemoptysis. So this is taken from this old sort of a study by Stein et al. That came from the US. So the predominant symptom will be always the dyspnea or short of breath. And when it comes to signs, tachycardia happens in 70%, crackles happens in 30%, tachycardia happens in 30%, and fourth heart sound or the gallop sound can be present in 30%, and accentuated P2 sound can be heard in 23%, and circulatory collapse happens in 8%. So these are all some of the signs and symptoms charted with regards to its frequency from this particular study way back in 1990s. So this was another study from Netherlands. So there's a lot of work that has happened from Dutch or Netherlands in this venous thromboembolism. So this was a study with meta-analysis of 19 studies, including 25,343 patients, where they showed the sensitivity of signs and symptoms is only 85% and specificity is very low at 51%. So which means to say the signs and symptoms cannot be hugely relied upon and they can be quite non-specific. But one thing for someone to remember is dyspnea is something that can happen, and the most commonest sign that we could see is unexplained tachycardia or a new onset AF is something that tend to happen. Comes to lab investigations, there can be neutrophilia in pulmonary embolism. They can be raised in the inflammatory markers like ESR, LDH, and AST. And ABG, initially there will be respiratory alkalosis because the patient is tachypneic and there will be high respiratory rate and the CO2 washout. So you would see respiratory alkalosis. But later on, the fatigue component will set in, and then you would have tissue hypoxemia leading to respiratory acidosis and metabolic acidosis, and high lactate due to the tissue hypoxemia that would have set in. And then you would have CO2 building up later on. And normal, usually AA gradient will be high, but it can be normal in about 6% of the patients. So this is some of the lab findings. And beta natriuretic peptide tends to go up even in pulmonary embolism. So this was again a study from the Dutch group done in 2013, where any patient with PE with a high BNP indicates that they are at a risk for complication. But as you see, the sensitivity for BNP is low at 60% and specificity also is low. And troponin also can increase in 30 to 50% of the patients with pulmonary embolism. And it only indicates that these are the patients at a higher risk of adverse outcome. ECG can be abnormal in 70%. The typical S1Q3T3 can be present, RVH with strain can be present, RBB can be present, or non-specific T inversion in the precordial leads can be present. So what are the chest X-ray findings? So this was again charted from this particular study. Atelectasis can be present in 69%, pleural effusion can be present in 47%, and in 12% of the cases it can be normal. So these are some of the non-specific. I'm sure you would have seen that wedge-shaped opacities that can be seen on the X-ray. So those are some of the obvious signs that one could see. So this is the typical ECG in pulmonary embolism. So you have S1 here, you have Q3, you have T3. There is a small R wave, there is a non-specific T inversions with RVH with strain sort of a pattern. So any combination of these or even RBBB is something that one can see. So what about CT? So this is a study which came in JAMA by the Dutch group, putting a CT based sort of an algorithm for diagnosis of PE. So this is just a quite intuitive sort of a algorithm. So if there is a suspicion of PE, so you need to ascertain clinically whether there is a suspicion of PE or there is no suspicion. If there is a high index of suspicion of PE, just get a CTPA. And CTPA is negative, PE is excluded, and CTPA is positive, PE is confirmed. If PE is unlikely, where your clinical suspicion of PE is very low, then get a D-dimer assay. If D-dimer has a good negative predictive value, so if it is less than 500, if it is more than 500, obviously the suspicion is high, you'll get a CTPA. If it is less than 500, it has a good negative predictive value, PE is excluded. So this is a simple algorithm that radiologists can remember. High index, just get a CT. If it is a low index, still you want to rule out PE, just get a D-dimer, and that would help you to determine whether you want to go ahead and do a CT or just ignore or discount the possibility of pulmonary embolism. So D-dimer has a good sensitivity of 95% and it has a very good negative predictive value, but it has a very poor specificity of 40 to 68% and a poor positive predictive value. So D-dimer less than 500 by quantitative ELISA or semi-quantitative agglutination definitely excludes PE. So D-dimer could be utilized as a tool to rule out PE. So what about CTPA? So this was a very landmark study, PIOPET study, which puts the emphasis and importance of or the value of CT in picking up a pulmonary embolism with a reasonably good sensitivity of 83% and specificity of 96%. And CTPA with venous phase increases the sensitivity to 90 and 95%. And CT also helps in identifying the clinical probability of PE with a good positive predictive value up to 96% and negative predictive value up to 98%. So all in all, this PIOPET 2 study, which came from the US group, was a landmark study which puts emphasis on the role of CT to pick up PE with a good sensitivity, good specificity, and good positive predictive value. So this is some of the CTs from our own ICU, which shows PE. So as you see, this is the left main pulmonary artery, and you have this filling defect with a huge thrombus there. So these are just the images. I'm sure every listener here would have seen CTs like this in their unit, having pulmonary embolism here with a filling defect in the left main pulmonary artery and the subsegmental arteries. So when it comes to CT interpretation, so the whole classification as to where the pulmonary thrombus is sitting is based on the branching of the pulmonary artery. So this is something we discussed in our master class. So the presence of thrombus is denoted to the branch of the pulmonary artery supplying particular segment of the lung, and this is the 3D sort of a imaging of the branching of the pulmonary artery, and every branch of the pulmonary artery in relation to the segment is coded with A1, A2, A3 up to A12. So the easiest way to remember, so this is how the zones are divided with the segmental branches, and you would have seen common CT reporting saying A2 segmental branch having a filling defect, or A3, A4. So this is the easiest one to remember. So on the right, you have up to A10 you have. So A1, A2, A3 in the upper lobe, and right middle lobe you have A4, A5, and right lower lobe you have A6, A7. So just remember this in a clockwise on the right side, and A6, A7 in anti-clockwise here, so in the lower lobe. So this is just for your understanding as to how the radiologists look at the segmental presence of filling defect in the CTPA based on upper lobe, middle lobe. So A1 to A10 is what is denoted as to where the possible filling defects would be occurring. So then you have a lot of these prediction models. So I wouldn't expect any of our trainees to remember all these prediction models. These are all present on the app. So you just have to put the risk factors, and the apps will show you what is the possible risk. But the easiest way to remember is the highest points, as I have reiterated, is put on someone with an underlying cancer or previous vascular event, previous venous thromboembolism, ACS, or previous stroke, or presence of underlying thrombophilic state gets the maximum score. As you see, cancer, VTE, thrombophilic gets the maximum. And the other lesser conditions like heart failure or obesity, all that get a lesser point. So this is a Padua risk assessment where they showed that high risk patients, if they're on anticoagulation, the VTE frequency was 2.2 as compared to 11% if they were not on anticoagulation. This is a very popular Wells criteria. Again, here you see the risk is more for someone with a past DVT or VTE, or someone who have symptoms of PE, and so those get the higher points. And these are some of the online tools that you have where you put in the risk factors, it gives you the risk stratification. So this was a study which came in CHEST, which clearly shows that there is a good correlation between the risk factor and the risk of someone developing venous thromboembolism. As you see, if there are no risk factors, the risk of developing venous thromboembolism was 0.4 to 0.5%, as compared to the group which had risk factors, when the risk significantly increases to 8 to 11%, clearly indicating it is imperative and important to identify patients who you are seeing whether they qualify in being at a high risk of developing venous thromboembolism, and they need to be put on anticoagulation so that the development of venous thromboembolism could be avoided. Then you have this PERC criteria. This is for a low risk. So this is again to identify patients who are at a very low risk of developing PE, who otherwise would not need thromboprophylaxis. And so this is used for patients where the prevalence is less than 15%, where the occurrence of venous thromboembolism would be less than 15%. In those patients, this PERC criteria can be applied, where basically it tells patients who are at a lower risk group, age less than 50, no hemoptysis, no estrogen. So it's basically a rule out sort of a criteria. So this is just to give you, there are zillions of criteria. So what I've shown you is Padua risk criteria, Wells criteria, improve criteria, and PERC criteria. So there are multiple criteria. You can use any of them, and there are online calculators for that. So there's no rocket science in this. But for all my listeners, you can keep this as a risk factor summary. Anyone who is more than 40 years, who has no mobility for more than or equal to 3 days, and with one of the thrombotic risk factors, which I mentioned, someone who's had a previous venous thromboembolism, or who has underlying thrombophilic state, or who's had a previous coronary event, previous stroke, or a heart failure. So all that real picture you remember. If any of these, they qualify as having a risk for developing venous thromboembolism, and you should entertain in your mind to put them on thromboprophylaxis. So all ICU patients, all sick ICU patients considered high risk for venous thrombosis. So this, if you remember this should be good enough for you to stratify patients as to who are at a risk of pulmonary embolism. So when patient develops pulmonary embolism, so treatment is resuscitation, because as you see, the first symptom they would have is dyspnea and tachypnea. So oxygen supplementation is something that should be given. If they're in shock, I think this is diabolical how you give. So it's sort of mini allocards based on the fluid responsiveness, based on the principles of fluid responsiveness. So you would obviously look into the IVC, look into the fluid status by your dynamic measures of fluid responsiveness, and then ascertain if they're fluid responsive. But you have to be very cautious because RV is a diabolical situation. So if you give more fluid, it can lead to problems. If RV is underfilled also, the cardiac output can get affected. So mini allocards is the way to go after assessing your volume responsiveness. So right ventricular dysfunction is something that would be present, and right ventricular failure and right ventricular ischemia is something that would be present. So your whole concept of preload optimization, afterload optimization, optimizing myocardial contractility will remain, and measures to reduce the stress on RV has to be put in place. So vasopressors to optimize your mean arterial pressure with noradrenaline or norepinephrine, and dobutamine when there is a low cardiac output state, because there will be reduced LV filling and lowering of cardiac output. So you have to accentuate the cardiac output by adding dobutamine after you have made sure that the patient is in a euvolemic state and a reasonable map is attained with noradrenaline. Dobutamine is something that one could add to improve the cardiac output. So definitive treatment of pulmonary embolism would be anticoagulation. So if they are in shock, then there is an indication for possible thrombolysis. Surgical embolectomy is something that is done as a desperate measure. So thrombolysis is something that one would consider in hemodynamically unstable, where there is acute right ventricular failure signs or RV dilatation is there with all those signs that we spoke about. So persistent hypertension and RV dysfunction is an indication for thrombolysis, and this should be considered within 48 hours of someone having developed pulmonary embolism. So is there evidence for this? So there is this PITHO trial which came from the Germany, where they did thrombolysis in hemodynamically stable patients, and they found significant benefit in minimizing the hemodynamic collapse by using thrombolysis. Although there was, in this study, there was no outcome benefit with regards to mortality, and there was increased risk of bleeding when they use thrombolysis in hemodynamically stable patients. So catheter guided thrombolysis is something that could be considered. So this was a study that came from US group in 2017 by Thakur et al., where, as you see, the catheters were put into pulmonary artery, and the pulmonary thrombus was lysed using intravascular thrombolysis, and they found the survival rate was very good at 87%. And IVC filter, where there is a contraindication for anticoagulation or thrombolysis because of stroke or any other reason. So IVC filter is something that could be contemplated. So there was this French study called the PREPIC study, which showed the use of IVC filters significantly reduced the risk of recurrent PE, although there was no difference in mortality. As you see, thrombolysis also, there was no difference in mortality, but there was a reduction of hemodynamic collapse. And even in IVC filter, it reduces risk of PE, but there was no difference in death. So prognosis of pulmonary embolism. So they have used another score called pulmonary embolism severity index, which indicates that these patients are at a low risk of 30-day mortality. This PESI score came from the Switzerland group. Basically, class 1 and class 2 score indicates that the risk of mortality, 30-day mortality, is very low. And these are the indices for the PESI score. So where again, as you see, there is more points put for someone with an underlying cancer, heart failure, and these are the points. So if it is class 1 or class 2, the mortality is very less, and the mortality tends to go up when the score increases up to class 3, class 4, class 5, where the mortality is 24.5. So all these scores, I wouldn't expect any of you to remember. So they're all readily available on apps. So you can put in the scores, and it will give you the final sort of a score once you feed into the variables. So with regards to chronic treatment and prevention of recurrence in PE, so there are various guidelines that has come from various groups, American College of Chest Physicians, American College of Cardiology, all these sort of associations have come out with guidelines. So the key is anticoagulation, unfractionated heparin. You have a choice between unfractionated, low molecular, and fundaparinox. So unfractionated heparin is something that is considered where you have acute kidney injury where creatinine clearance is less than 30 ml per minute, or there is potential acute discontinuation of this. So grade 2C is the recommendation. But low molecular weight heparin is what is preferable. As you see, it gets a grade 2B recommendation. And oral anticoagulation, monotherapy can be with apixaban and rivaroxaban. And if edoxaban or dabigatran, it has to be overlapped with heparin and then change over to oral. So the duration of anticoagulation after someone has developed PE, for proximal DVT, the duration is for 3 months. That is grade 1B recommendation, strong recommendation with the moderate evidence. For distal DVT, also the duration of anticoagulation is 3 months. And DVTs or venous thromboembolism, there is a provoked and unprovoked. Provoked is where there is an inciting event or underlying risk factor. After the resolution of risk factor, the long-term anticoagulation could possibly be stopped. But when there is recurrent DVT, the suggestion or the recommendation is the anticoagulation has to be continued indefinitely. So for the provoked, once there is reversal of the risk factors, one could consider stopping of the anticoagulation. So 30% of the PE was found to be due to unprovoked reason. And any pulmonary embolism which is not provoked, which means there's no clearly defined underlying risk factors which cannot be reversed, there is 2 to 3-fold increase in the risk of recurrence in unprovoked. So unprovoked is more troublesome because the recurrence rate is much higher as compared to the provoked. Provoked means where you have a definitive underlying risk factor which can be corrected. So special patients with acute venous thromboembolism who require, as I said, if there is a contraindication for anticoagulation, then IVC filter is something that one could consider, and you have this trial that substantiates. So in patients with malignancy or pregnancy, low molecular weight heparin is what is suggested, and all the newer oral anticoagulations like factor 10 inhibitors and direct thrombin is not recommended in patients with underlying malignancy or pregnancy. In patients with iliofemoral DVT, one could consider thrombectomy or thrombolysis, localized thrombolysis or catheter guided sort of a thrombolysis. And after post-thrombotic treatment, there has to be a lifestyle modification with early ambulation, and graded compression stockings is something that one could consider. All this get a weaker recommendation with a low level of evidence. So the things to consider when you are treating for anticoagulation or PE is the dosing has to be individualized to what sort of anticoagulation one is using. If unfractionated heparin is being used, so it has to be maintained to a target of 2.5 to 4 times the baseline, 0.3 to 0.7 units per ml. So low molecular weight heparin, when that is being used, vitamin K antagonist has to be overlapped before changing it to orally. So we cannot change to vitamin K antagonist like warfarin without overlapping with the low molecular weight heparin, at least for 5 days. And INR has to be maintained at 2 to 3. That gets a strong recommendation with a good level of evidence. When someone is on a vitamin K antagonist or anticoagulations, platelet count has to be monitored. And thrombolysis, we discussed about it, IVC filter we discussed. There's something called chronic thromboembolism, pulmonary hypertension, which means after they're fully recovered, 5% of them develop chronic post-thromboembolism pulmonary hypertension. For this, they have to be investigated with the ventilation perfusion scan, CTPA, and echo. And if ventilation perfusion scan shows more than one segment involvement, then long-term anticoagulation is something that is suggested for these patients who have this chronic pulmonary hypertension after thromboembolism. So that's about it, folks. So I just took you through the overview of the whole pulmonary embolism and the available evidence for all the interventions that one would do. So you can rehear to this lecture visiting my website www.drpradeeprangappa.com, and you can post any questions if you have any. So thank you, one and all.